Thanks to all the audience who follows our broadcast. We are live in the first day of the 2020 International Web-Based Neurosurgery Congress. We hope you have enjoyed all the presentations and talks that have been presented so far. Remember, we're streaming on YouTube Live too. Well, we have the honor today of having Dr. Christopher Loftus. Dr. Loftus is a renowned neurosurgeon from the Temple University Lewis Katz School of Medicine. He is the first vice president of the World Federation of Neurosurgical Societies. He is also professor of neurosurgery, chief medical officer of the Division of Neurological and Physical Medicine Devices, Office of Device Evaluation, Center of Devices, and Radiological Health. Now, Dr. Loftus is going to share his lecture, Anticoagulation, Hemostasis, and Reversal in Neurosurgery. Please type your questions in the Q&A section. We will read them after the end of Dr. Loftus' intervention. Welcome, Dr. Loftus, and thank you. It's all yours. Thank you very much.
It's a pleasure. First, let me just tell you, I'm going to make this window small. Let me just tell you that I really commend you for having this Congress, for making this education free for people all over the world. It's a wonderful thing you've done, and I'm happy to take part. My name is Christopher Loftus. As you heard, I'm professor of neurosurgery in Philadelphia at Temple University School of Medicine. And I just finished my term as first vice president of the World Federation. And for those of you who are involved with the World Federation, great. If you're not, you should be. It's a wonderful organization. I love it so much. So you should be involved. And I worked for the US FDA, which as chief medical officer, which you just heard. For the last 3 years, I do this. But I work in neurological devices. So I'm going to talk about drugs today. Nothing I say today has anything to do with my work at the FDA, and it's only my opinion from clinical work. I do not speak about the opinion of the FDA. Oh, the slides won't advance. There we go. Yeah. Okay, great. So I work in Philadelphia, and if you come to Philadelphia, please come visit. Be happy to have you. Also, everything I say today, 4 years ago now, I published this book about anticoagulation and hemostasis by Springer. So most of the things I say today are in here, but some are new because the field changes very quickly. So if you're interested, I recommend it to you for consideration. And you can probably buy it used cheaply on Amazon, probably only a few dollars, I suspect. I'd like to talk to you just, for example, I'll show you some cases of hemostasis in neurosurgery, and then we're going to talk about the physiology. Let me just start, and you'll understand. I'm having a little trouble with this movement. I'm sorry. So the fundamental questions, whenever I see a patient who has either antiplatelet or anticoagulation therapy, we need to ask some questions as clinicians. Does the patient need to be on that therapy? In many cases, are they going to need surgery? And what are we going to do? Should we reverse the platelets or the platelet inhibition? Or should we reverse the anticoagulation, or should we wait? And if we do that, is a single dose enough, or do we have to repeat the doses over and over again? So here's the first clinical case I want to show you. I love to show cases where the answer is unclear and you have to think about it. So a 22-year-old man came when I was chief at Loyola a few years ago in Chicago, hit by a car. He came in intubated with a head trauma, bilateral contusions, as you would expect, and a bone fracture along the sagittal suture. But he was okay. His eyes would open. He was intubated. He had full strength. So on the first CAT scan, you see, as you would expect, multiple brain contusions consistent with traumatic hemorrhage, and the ventricles are already a little tight, I would think. In addition, the chief resident, so here's a fracture along the sagittal suture, right? And I didn't think much about this, but the chief resident said to me, Dr. Loftus, we should do a CT venogram. And I said, okay, let's do that. And sure enough, the sagittal sinus is occluded a long way back, okay? A long way back, well beyond the coronal suture. So this is a risk, right? The sagittal sinus occluded. So now what do you do? What are you going to do about this? I mean, do you give heparin for the thrombosis? That's what we would usually do, but the patient has contusions, so we're worried about that. Or maybe do you not give heparin in a trauma patient because of that? Or do you do external ventricular drain right away, or put a monitor, or you do decompressive surgery, which I usually don't do over the sagittal sinus if there's a possibility of injury. Or now maybe you could do an endovascular thrombectomy. So, we didn't know what to do. So for the first thing we did was watch it for a while. And sure enough, the exam deteriorated quickly because of the venous pressure. And we placed a right frontal EVD. The resonance were good because you said the ventricle was small. That wasn't easy to do. The opening pressure was 15. Sure enough, we did another MRI and MRV, and he's showing evidence of venous infarct and persistent sinus thrombosis. So we had no choice. We had to start a heparin drip. We did that on the second day. The intracranial pressure went very high. We could not manage it except with a pentobarbital coma and hypothermia. That did get it down into the single digit range, and we kept it there for a long time. Here's the MRI. You see he's getting in trouble with venous infarction, as you can see. We kept it there for a long time. This guy could not lie down in bed. We had to keep him sitting upright in the bed, even though he was in a coma. If we put him down, the intracranial pressure goes up. 19 days after, look, we did a CTV, and the sinuses open again. This guy walked out of the hospital. We got him through this. It was dangerous we thought it was dangerous to give him heparin with the contusions, but we never had a bleed. He walked out of the hospital. He did well. So that was a difficult case. So in this presentation, I want to talk to you about the physiology of antiplatelets and anticoagulation, a little about the pharmacology, and I want to show you more cases. And the first maxim is bleeding is our enemy. We're surgeons. We don't like bleeding. It makes things difficult for us. Coagulation is our friend. The natural physiology of the body is good for us. Coagulation helps us in taking care of patients. So our central principle, we don't want to operate on any patient with compromised coagulation, except for this, the king of all neurosurgery procedures, which is the carotid endarterectomy, where we have to anticoagulate the patient. But aside from that, no. So we need to understand and deal with antiplatelet drugs, heparin therapy, vitamin K antagonists like warfarin, and the novel oral anticoagulants, so-called target-specific or NOACs, novel oral anticoagulants, the new drugs that we use now. And here's what I want to talk about to you today. I want to talk to you about the drugs, the classes, the mechanisms, how they work. Then I want to talk about how do we shut them off? How do we shut off if we have an emergency? Aspirin, the thienopyridines, which the example here is Plavix, but it's Plavix, Brilinta, or Effient, the vitamin K antagonists like Coumadin, and the NOACs. And the same thing, how do we shut them off for elective surgery? The same process, but the thinking is a little different. Who needs a bridging strategy where you can't just shut them off, you have to do something else? And then when can you restart them post-op? I'll tell you this, there's no good answer to this question, okay? Every surgeon has their own answer. For the purpose of this talk, we can use interchangeably novel oral anticoagulant, NOAC versus SOAC versus DOAC. They're the same things, they're just three different names for the same drugs. So, why is anticoagulation a problem? Well, a number of reasons. There's a lot of elderly patients, okay? And the elderly patients, they fall down a lot and they have a lot of traumatic brain injury. So if you look at all the trauma-related deaths in the United States, 25% are in elderly patients. If you're an elderly patient and you're taking an antiplatelet drug, your chance of dying is 23% versus 9% if you're not taking an antiplatelet drug, just aspirin alone, okay? So this leads some people, to advocate to give a platelet transfusion to have every head injury patient, even if the CAT scan is normal. We're going to talk about that in a little while. I don't agree with that, but we need to think about when you should give a platelet transfusion for people who have traumatic brain injury when they're taking antiplatelet drugs. There are expanding indications for antiplatelet and anticoagulation therapy, and these NOACs are coming into common use, but we're just now starting to get, and we'll talk about all this, the reversal agents that are just arriving, and they are expensive, and the hospital doesn't like to give them, and I'll show you all that. So who do we see? What kind of patients do we see who might be taking these drugs? Atrial fibrillation is a common one. Prosthetic heart valves. These patients require warfarin, as you know. Deep vein thrombosis with or without pulmonary embolus and or recurrent DVT. Endovascular devices, and they can be, intracranial endovascular devices or carotid endovascular devices or in the heart. Okay, vascular devices in the heart. Hypercoagulable states, and you know this patient. You've seen this patient. Unknown therapy. Patient comes to your office. You're talking about a surgery. They say, I take Coumadin. I take warfarin. You say, why? They say, I have no idea. The doctor gave me warfarin 30 years ago. I take it ever since. I always check my INR. I don't know why I'm taking it. We see those patients. You've seen them too. Let's talk about the physiology of the platelet. So as you know, the platelet forms a plug at the site of on the endothelial site of a vascular injury. There are 3 receptor sites on the platelets where antiplatelet agents can work. We don't need to talk about 2B3A because these drugs are given in a controlled situation in the hospital. They're short-lived drugs, and we don't have to worry about those right now. We talk about aspirin, works at the COX-1 inhibitor, and we talk about thienopyridines, in this case, Plavix, Brilinta, and Effient. You may call these different names in different countries, and I apologize for not knowing that. These are P2Y12 inhibitors, but they all do the same thing. They make the platelets not work, and they cannot be reversed except by giving more platelets. For anticoagulant drugs, there are parenteral forms, IV forms, and this is heparin. Okay, heparin is either unfractionated heparin or the low molecular weight heparin, commonly known to us as Lovenox or enoxaparin. And then you have parenteral antithrombin drugs, and there's really only one that we use, argatroban. And we don't use that very much. You use this drug when somebody gets heparin-induced thrombocytopenia. I'll show you a case of that later on. Of the oral anticoagulants, the ones that are the classic, the vitamin K antagonist, is warfarin, Coumadin, warfarin. The other ones we don't use. And now the NOACs, there are 5. Okay, dabigatran, a direct thrombin inhibitor, and 4 factor 10A inhibitors, rivaroxaban, apixaban, edoxaban, and betrixaban. These agents act at different sites in the coagulation pathway. So the vitamin K antagonists work against many of the factors in the coagulation pathway. The novel oral anticoagulants come as 2. The direct thrombin inhibitors, which work here, and they block the thrombin from the conversion of fibrinogen to fibrin. The factor 10A work here. They block the conversion of prothrombin to thrombin. Either one works very well at preventing coagulation. These are good drugs, and they have good uses. Okay, so if you look at don't look at everything, the slide is too busy, but if you look at the green line, these are drugs given for atrial fibrillation, and the green means that they are superior to warfarin in the prevention of stroke. So all 3 drugs in these particular studies were better than warfarin in preventing stroke in patients with atrial fibrillation. What's the problem? A little gastrointestinal bleeding, particularly with dabigatran and a little bit with Xarelto, not with Eliquis. But for stroke prevention, most people would accept a little gastrointestinal bleeding. The problem with these drugs is that classical clotting assays, which we use to monitor warfarin, for example, don't work. So your PT, your APTT, and your INR, they are not accurate to measure the concentration of a novel oral anticoagulant. Look at this example and just look at these 3 circles. So this is the change from baseline of the INR, and this is the concentration of apixaban. So in this particular case, for a 50% change in your INR, this could occur at 3 different concentrations of apixaban, 50, 250, or 600. So there is almost no relationship between the INR and how much apixaban is in the patient's blood. And that's a problem. Now, if you want to measure the drugs, I don't know if you have it in your hospital. We didn't have it at first, now we do. You can use an anti-factor 10A assay, and this will work. So here, for example, is an assay. The PT, the INR is here, and the apixaban concentration is here. And no matter how high the apixaban goes, the INR doesn't change a whole lot. But if you look here, the apixaban goes up in this axis, and the anti-10A goes up here. So this is a nice linear relationship between increasing concentrations of apixaban and increasing anti-10A activity. So if you have to monitor your NOACs, you need to use an anti-factor 10A assay, and you get your hematologist to help you with that. So where do we need to take action for antiplatelet or anticoagulant drugs in patients that we treat? Trauma. Emergencies, non-bleed emergencies that present on these drugs. Trauma is a big one, right? Or a brain tumor, perhaps, that may be swelling and you need to do something. Or an acute disc, like a Cauda-Equina syndrome, perhaps. Or a shunt patient with hydrocephalus. This is rare. Hydrocephalus requiring a shunt revision. I must admit this is rare because most elderly patients have NPH, and that's not really an emergency situation. Bleeds that occur on antiplatelet or anticoagulant drugs. So I'm going to show you cases of this: brain bleeds or spinal bleeds, or elective surgery patients on the drugs. Do you bridge it, or can you just stop it? How do you do it? Or We see patients who we do surgery, and after surgery, they develop a need for antiplatelet or anticoagulant therapy that we had not anticipated. Maybe they get a deep vein thrombosis or pulmonary embolus, or sometimes you get a sinus thrombosis. I'll show you a case of this. Or many times they have an MI and they need to have a coronary stent placed. Or somebody comes to the office and they need a spinal tap and they're taking antiplatelet drugs or anticoagulation drugs. What do? I'll tell you right what I do. I don't do a spinal tap on those patients. No, thank you. I've seen problems from that. So we asked this question before, and let's ask it again. Do we have to reverse anticoagulants and antiplatelet drugs in trauma patients and also in patients who come in with spontaneous, non-traumatic intracerebral hemorrhage? Let's look at the evidence for this. I'll tell you right now, if a patient comes in with trauma or with an intracerebral hemorrhage, we're going to reverse an anticoagulant drug, whether it's warfarin or whether it's a NOAC. We're going to reverse that. The real question is, what do you do about antiplatelet drugs? In other words, do you give these patients platelets or not? And the answer to that is unclear. So let's ask the question this way. You have a head injury patient or a patient with intracerebral hemorrhage who takes antiplatelet drugs. It doesn't really matter whether it's aspirin or a thienopyridine. Do you transfuse empirical platelets? Do you just give a platelet transfusion for trauma, particularly for trauma, with no bleed on the scans, a little bleed, a big bleed? Yeah, I think a big bleed, you're going to say yes. A bleed requiring surgery, you're going to say yes. But here's where the problem lies. No bleed or a little bleed. Well, why wouldn't you give platelets? Because of this transfusion-related acute lung injury. It's a real issue, and the hematologists fear it. I must say, I've never seen a case, okay? And I've given many, many platelets over the years. But if you talk to the hematologist, they tell you, be careful about giving platelets. You can get a lung injury, and it can be fatal. It can be deadly. So it's a worry. So here's a case. Okay, this is a case from Chicago when I was at Loyola a few years ago. 75-year-old woman. She had a coronary stent. She's on aspirin and clopidogrel and Plavix, okay? And like many old people, she fell down the stairs, okay? The husband finds her unconscious at the bottom of the stairs, minimally responsive. She comes in, her GCS is 11. My resident team examined the patient, and they wrote an order. It's a patient's on trauma service, okay? They see a little traumatic subarachnoid hemorrhage, maybe intracerebral hemorrhage on the scan, and they say, we want to give platelets to this patient, okay? They recommend to the trauma team. They can't write the order, they make a recommendation. So they say, please give platelets, please give as soon as you can. But the trauma team, they took an hour, maybe hour and a half to write the order, okay? So the platelets are ordered, and then the nurse takes another hour to send the request. And before the platelets go in, my residents get another call. Now she has a dilated pupil, right? And they go back and she's had a fatal intracerebral hemorrhage, okay? So nothing could be done. Exam is 3T. Okay, it's over, as you can see. This is not compatible with life. So the lesson here, and we did not operate on this. The family didn't want it. She expired. She died. The lesson is, if you're going to give platelets, do not delay. Give them right away. Now, talk about this. This is the so-called patch trial. This is not trauma. Okay, this is spontaneous intracerebral hemorrhage. Should you give platelets? Here's a European. I can't see who's listening to this talk worldwide. Maybe many of you are in Europe. Maybe you know this trial better than I do. Maybe you are investigators. I have no way to know. This is a multi-center randomized trial done in Europe for spontaneous intracerebral hemorrhage. Platelet patients were on antiplatelet therapy. They were randomized. Either they get standard care or they get standard care plus a platelet transfusion. 190 patients. There was no benefit to a platelet transfusion in these patients in terms of the outcome. As a matter of fact, it looked like there was a trend that the outcome might actually be worse. Certainly, there was no difference in the outcomes clinically or on imaging. So the patch trial would suggest no platelet transfusion for spontaneous intracerebral hemorrhage. Now, that's a little different than trauma. So when I looked this up to prepare this talk maybe 1 year ago to give in a different location, Jack Jallow, very good surgeon. He was a faculty member of mine when I was a chairman. I'm on the faculty now at Temple. I used to be chairman of the department 5, 7, 8 years ago. And Jack was one of my faculty members, very excellent surgeon. Pascal Jabour is also an author, very excellent endovascular neurosurgeon. They created this algorithm for what you do with intracerebral hemorrhage, whether it's traumatic or spontaneous, in patients taking antiplatelet agents. So here's what they do. It's very aggressive, okay? If the patient comes in with any kind of hemorrhage, aspirin alone, they give 5 units of platelets, okay? If the patient's taking a thienopyridine, which means, Plavix, Brilinta, or Effion, okay? If it's a small bleed, they give 10 units of platelet. They double the dose. If it's a large bleed, they give DDAVP, and DDAVP essentially creates a super platelet that works a little better. So if you really need it, a dose of DDAVP is useful to make the existing platelets work. Then they give 10 units of platelets also, and then they give 10 units of platelets every 12 hours for 4 days. So very aggressive approach. They weren't particularly worried about lung injury. And, I frankly, it's not a lot different than my approach. I don't follow these dosing exactly, but I'll tell you, if I see anything on the scan, anything, I give platelets now because of the patients that I saw who died because we didn't. So let's talk about reversal strategies for emergency surgery, okay? Whether it's a hemorrhage or another kind of emergency surgery. So for antiplatelets, it's easy, okay? You can't, except for DDAVP, you can't make sick platelets work again. Once they're poisoned with an antiplatelet, they don't come back. You need new platelets. And the only way to give them is to give the patient new platelets. So if you want to reverse an antiplatelet agent, we give them what we call a 6-pack of pooled fresh platelets. In high-risk situations, like an intracerebral hemorrhage, we give more than that, like Dr. Jallo does. We give more, and we give DDAVP, and we continue the transfusions for 48 hours, as Dr. Jallo did as well. So a very reasonable choice for that. For anticoagulants, you need to know the different reversal strategies for the different anticoagulants. So for heparin, you can give protamine or you can just turn it off. And if you can wait a few hours, it'll just go away. For enoxaparin or Lovenox, you can also give protamine and it will work. And the half-life is a little longer. You really need to wait at least 12 hours if you don't reverse enoxaparin because the patient will still have activity. For warfarin, it doesn't go away very fast for the vitamin K antagonist. So you got to give vitamin K for the long term, but vitamin K won't reverse it immediately. The immediate reversal is either fresh frozen plasma, but the problem is a lot of volume. So if you have a patient with intracranial pressure, you don't want to give all that fluid. So now we give 4-factor PCC, which in our country we call Kcentra. You may have different names for it, but we like 4-factor PCC. For the new drugs, we used to give 4-factor PCC, or sometimes we gave Novo-7, and this works. Now the drug company wants to sell you these drugs, and they'll tell you 4-factor PCC doesn't work, but they're wrong. It works, and you can use it, and we used it for years, and it works fine. These may work a little better, but I leave you to your choice. For the direct thrombin inhibitors, there now is a drug called idarosizumab or Praxbind, which is a direct reversal agent for dabigatran or Pradaxa, and it works. For the 10A inhibitors, we still give 4-factor PCC, but there is a new drug on the market. It is only cleared for in our country, only cleared for apixaban and rivaroxaban. It's called Andexxa, okay? And I leave it to your choice whether you can get it on the hospital pharmacy and use it, because the problem is the price. Let me show you a patient. Here's a patient I saw at Loyola. I'm sitting in my office about 6 o'clock at night. We're working on a manuscript on the computer. And in comes the chief resident. Name was Paul Ackerman, nice guy, good surgeon. In comes the chief resident and says, Dr. Loftus, we need to go to surgery right now. And I said, okay, why? He says, well, I got to show you these scans. So he has a patient, 55 years old, with 2 mechanical heart valves. He's a dialysis patient. He takes warfarin. He has a renal cell carcinoma and everything else imaginable, colon cancer, you name it. Many comorbidities. His INR is high at 4.3. His platelets are okay. And the CAT scan, he's got a posterior fossa hemorrhage, and maybe he's starting to get a little hydrocephalus. I think the 4th ventricle is almost gone. Certainly he's going to get hydrocephalus. So I agreed, we need to go to surgery. We did a CT angio. They called this study negative. I thought it was negative, but if you look again, I actually don't think it is negative, but you'll find out why. So we asked the questions, will surgery be needed? Yes, we need to go surgery right away. Does he need anticoagulation? Yes, he does, because of his heart valves, but he can't have it right now. So we have to reverse it. Should we reverse it? Yes, we have to reverse it right away. Is a single dose sufficient? We don't know yet, but we're going to follow the INR to find out. And how are we going to manage him post-op? So here's what we did. We gave him 4-factor PCC, K-Central. We gave him vitamin K also. We took him to the operating room, put a right frontal external ventricular drain, and then we took out the intraparenchymal hemorrhage. And it bled a lot. It was very bloody, more so than you usually see with a hemorrhage. Finally, old style, I took my finger and just fished it out and popped it out, popped out a lump. And you can see it was fine. And then the bleeding stopped immediately. We did a post-op CAT scan. He's fine. The guy did well. He woke up, did fine. His strength got better. We held his anticoagulation for 2 reasons. Because he had an external ventricular drain, so we held it for an indwelling device. We did not heparinize him. And we held it because this turned out to be a metastatic renal cell carcinoma. So that's why it bled so much. He had a vascular tumor. So we held this for 7 days. And then, we checked another scan at a week post-op and everything looks good. And you see the 4th ventricle is now more open, right? So that's good. We started him again on day number 9. We bridged him over with Lovenox with enoxaparin while we started warfarin, and then he got RT and chemotherapy. He did well. Now, here's another patient. We got a different strategy, a lumbar spinal epidural abscess, who came in with a neurological deficit, impending cauda-equina syndrome, fever. He'd already been treated with antibiotics for urosepsis, and he was weak in the legs, and he had a post-void residual, but his rectal tone was intact. So we needed to move it. His INR was 3.1. To move fast because of the cauda-equina syndrome. He's got, as you can see, this sort of phlegmon ventral at 3 different levels, and we wanted to decompress that. So we gave him 4-factor PCC. We did his laminectomy. The cultures never grew anything because he'd been treated. He got 6 weeks of antibiotics. Now, because he was only DVT, we just waited 18 days and started him back on Coumadin, and he did not need a bridging strategy, and he did fine. Now, what about, I'm looking at the time, but it's 4:25, so we're okay. Time-wise. Let's just go through and look at some more examples. Patients who develop unexpected needs for anticoagulation post-op. This is another case from Loyola because the residents made such good slides. This is Dr. Prabhu's case. Dr. Vikram Prabhu was one of my faculty members when I was chairman there, professor of neurosurgery, excellent surgeon, and a very nice guy. This was a patient of his who we had seen in the clinic who had a progressive right hemiparesis. Suffice to say, he had a parasagittal meningioma, rather standard meningioma, didn't really involve the sagittal sinus, but close, very close, okay? So he did a nice operation, took the whole thing out. He did have to take 1 cortical vein that was involved at the bottom of this tumor. You can't see it on this, maybe it's this, okay, who knows, something down there. And a nice operation, well done by a good surgeon, but post-operative day, that evening, he starts to get aphasic with a right hemiparesis. You can guess what's going on. He's got a venous infarct. And so that's okay. People get, we don't like it, but people get better from a venous infarct. But the radiologist, I can't see it, but the radiologist said that they could see a thrombus in that vein that extended into the sagittal sinus. And so the question then became, what do you do? I mean, are you going to anticoagulate this guy with that thrombus? And he came to me and we talked it over. And I said, I didn't think he should be heparinized, but he had a different choice. And he heparinized the patient that evening. And sure enough, after the heparin drip starts, he gets heparin-induced thrombocytopenia. So you take it already as a bad problem and you make it worse. You switched it over to argatroban, as I said in the beginning. Remember I said a parenteral direct thrombin inhibitor, argatroban. That worked. He was on that for 1 week. Then they switched him over to aspirin, transferred him to rehab. Ultimately, the sinus was patent on a CT venogram. The patient ultimately did well after he recovered from the venous infarcts. But that was a tough case. Now, what's our experience with these novel oral anticoagulants? Because, they're new, maybe 5 years, 6 years, 7 years. And we're used to warfarin. We're not used to this. Remember, for heart valves, you can't take them. For a heart valve, you've got to take warfarin. These are good drugs, okay? Look at this. Compared to warfarin with the NOACs, compared to warfarin with the NOACs, essentially all the drugs except low-dose edaxaban are better at the prevention of stroke than warfarin is, okay? If you look at major bleeding taken warfarin, they're all better except for this one little outlier. It's not that far off. They're all better at preventing major bleeding when you're taking them for atrial fibrillation. What about intracerebral hemorrhage, the thing that we worried about since we didn't have an antidote? They're all better than warfarin at preventing intracerebral hemorrhage because the dosing is more tightly controlled and the half-life is shorter. That seems to be why. So if they're so good, why do we need an antidote at all? Well, look, sometimes you're going to see bleeding on NOACs. It's not that often, but you see an intracerebral hemorrhage, a subdural, an epidural, spinal hemorrhage, or a stroke that needs an EVD. Or maybe you need a vascular procedure of some kind that can't wait on a NOAC patient, like subarachnoid hemorrhage that needs an EVD. Or maybe they're going to go, for an endovascular treatment of a ruptured aneurysm. There's a short half-life, so a lot of time you can just wait it out. We'll talk about that. Why else would you need them? As we said in the beginning, non-bleeding problems. You have to put an EVD for trauma on a patient on a NOAC. Or you have procedures that just can't wait, like I'm going to show you a case of a brain abscess, or spinal diseases like a cauda equina, or maybe a shunt. And so you need to be able to reverse them. Okay, here's a case, another case from Loyola. 59-year-old pulmonary patient, atrial fibrillation, DVT, and PE. She's taking Xarelto. She comes in awake and oriented, but with a weak leg, okay? So here on the scan is discovered what looks like a brain abscess. And it's frightening because there's a little daughter abscess, and see how close it is to the ventricle. So we're very worried about the risk of a rupture into the ventricle and ventriculitis, which, as you know, is a very dangerous disease. So this needs to be operated on for both for diagnosis and for treatment. We went and asked internal medicine what they would do. They said, don't reverse, don't give 4-factor PCC, just wait 24 hours and do surgery. So we did that. Waited 24 hours, did an open surgery. The culture was nocardia. The patient recovered nicely, cleared to anticoagulate on postoperative day number 10. That's what happened. Post-op scans looked good. This lady did well. So that was a good strategy. So we didn't reverse that time. But if you have to reverse these drugs, what do? The best method, if you can afford to wait, is just to stop them. I'll show you the half-lives in the next slide. The longest half-life is 17 hours. Just stop them, wait for them to go away. We used to give 4-factor PCC for any of these NOACs, okay? And in many cases, I still do. We gave a couple times, gave Nova 7. We never gave 5. These are historical. We don't do hemodialysis for this. We don't give activated charcoal. But look at these, okay? You need to know this. For dabigatran, for the direct thrombin inhibitor, Praxbind is the approved drug for reversal. For factor 10A, for 2 of them, it's Andexxa, the approved drug. There's another drug. It's not on the market yet. Maybe it is overseas. It's not in the United States, called aripiprazine or siraparantag. Okay, that's a lot to say. They make many claims. They claim this drug can reverse Lovenox, heparin, and all the NOACs. If it can do that, it's quite amazing. The drug is in trials. I don't know where it's going to go. It's not available to us in the United States. In theory, using a specific antidote is better than the reversal warfarin because you're targeting the drug itself, whereas warfarin is not. 4-factor PCC is just replacing the factors that are missing. You need to know the infusion, and you need to know if you have to do redosing. Here's the problem, okay? Here's what these things cost, at least in the United States. Fresh frozen plasma is cheap, okay? $300 for a dose, all right? The trouble is you got to give a lot of fluid. 4-factor PCC Kcentra is a lot more money, $5,000 for a dose. We give Kcentra. We give Kcentra all the time. Praxbind isn't bad, $3,500. So if you get a patient taking dabigatran and need to reverse them, Praxbind is okay. The trouble is this, Andexxa. I mean, you can't believe it. To give a standard high dose of Andexxa to a patient to reverse a factor 10A inhibitor, $50,000 US. I mean, in our hospital, we can't get the drug. They're just not going to pay that money. So we use Kcentra. This is a good drug. We'd like to use it, but we just aren't going to pay that kind of money. Let's go to a different topic, and we're finishing up. We'll be on time. How do we best manage anticoagulants in patients who need elective surgery? We've talked about emergencies. Okay, once again, elective surgery. Antiplatelet drug, just wait 5 to 7 days. We just tell the patient, don't take your aspirin, don't take your thienopyridine. If you wait 5 to 7 days, it won't be totally gone, but you'll have at least 50% normal platelet function because they constantly are being remade. 50% is enough to get you essentially a normal surgery. So antiplatelet, we don't transfuse, we'd like to wait. For the vitamin K antagonist, if the patient is at a normal INR goal of 2 to 3 on therapy, you could wait for 5 days, and 90% of patients are going to have a surgically acceptable INR, which we call less than 1.4. And you're not in the dark because you check the INR before you go to surgery. So you know that it's okay before you operate. So we don't reverse for this. For the NOACs, as I said before, it's best to wait. But 2 of these drugs are cleared in the kidney. The rest are cleared in the liver. And if you have a low creatinine clearance, it takes 3 to 5 days. And you can't measure them. Well, this is an old slide. Now you can if you have an anti-factor 10A assay. And you might consider that. This is the slide of the half-lives. I put this slide in yesterday just in preparation for today's talk. The half-life of these drugs is at the most 17 to 18 hours. So realistically, you don't have to wait very long to get these drugs to go away. And then you either proceed with surgery on an empirical basis, or you could do an anti-factor 10A assay if you have it available to you. Now, who needs a bridge? I talked about bridging. There are some patients who are so sick and they need the anticoagulation so badly that you can't stop it for surgery. And those are patients like this: atrial fibrillation with a high CHA2DS2 VAS score greater than 3, or somebody has recent venous thromboembolism within the last 6 months, or thromboembolism and hypercoagulable, or mechanical heart valves, particularly the mitral position, which is the highest risk, or lupus with these conditions, or an antithrombin 3 deficiency. And honestly, if we see this, we call the hematologist. That's what we do. Okay. CHA2DS2 VAS, you see a stroke rate, only stroke rate per year. I mean, it's not terrible, but your rate really starts to go up once you get beyond 3. So those patients, we suggest 3 or above. You bridge those patients rather than taking them off the drug. These are my personal thoughts about how I manage anticoagulation for elective surgical procedures. By far, natural decay is best. If you can stop, just stop it. Let the patient come off the drug, and then for the ones you can test, you test before surgery, you do your operation, and then you decide how soon after surgery you're comfortable putting them back on. I'll tell you, I don't have a slide about this, but for me, if the patient needs it badly, I'll put them back on at 24 hours. If it's a cranial case, I do a CAT scan. If there's no blood, I'll put them back on the drug. I'm actually a little more nervous about a spinal case because of the confined space in the spinal canal. Would we ever, you may ask the question, would we ever reverse a patient just for convenience for elective surgery? And I suggest to you the answer to that is no, okay? Just let it go away, because reversal, number 1, is expensive. And number 2, has the risk of thrombosis, including cardiac thrombosis. And I can't see any reason to put that patient to that risk for my own personal convenience in the surgical schedule. That's not right to me. But there are patients where a drug holiday would increase the risk if they're waiting. And so if you need an ultra short window, which is rare, but we showed those cases where you need a bridge, we would bridge, and usually that means bridge with Lovenox, okay, and not reverse. But really, we'd rather change the surgical date, like my friend, Mr. EB. And I put this in, it's a nice guy. The guy had a carotid in Chicago, and he came in that morning. And, you know, we took him off his Plavix a week before surgery because I don't like to do a carotid on Plavix. It bleeds too much. And he said, you know, he was an old man. And he said, you know, I think I might have taken a Plavix this morning by mistake. I don't know what, I took some pill, I don't know what, my heart pill or Plavix. And so I just said, do I give him a platelet transfusion and do his carotid, or do I send him home? And we just sent him home and operate him 2 weeks later. And that was fine. He wasn't so happy, but it was the right thing to do. Now, I haven't shown you any bleeds on NOACs because we don't see many. We didn't see much of this problem yet. The blood levels are better controlled. Not that many patients are taking the drug, but we still need the reversal agents, you know, for all the reasons I showed you. But then after I made this slide, we did find this case. A lady came in, 77 years old, DVT and pulmonary embolus. She's on Xarelto. Okay, so she's on a NOAC. She fell down the stairs. It's a common problem. Fell down the stairs. She got an intraparenchymal hemorrhage. We gave her case Centra at admission. So we reversed the NOAC with 4-factor PCC. And I can just show you this. Okay, she's got a big intracerebral hemorrhage on the first scan, and then she's got it 6 hours later. And it really never changes, 18 hours and then 42 hours later. So I don't remember. This wasn't my patient. I don't remember exactly how she turned out. But I will tell you that reversing the NOAC in that case with a single dose of 4-factor PCC arrested the progression of this hemorrhage. And I suspect she recovered from this, probably with the neurological deficit, but she recovered. Now, just as my last slide, just to show you that even we think we're so smart, but we get patients and we simply don't know what to do with them. This lady came in, it wasn't last weekend now, it's about 6 months ago. But you know, you're going to get patients like this, 77 years old, right? She comes in and she tells us, doctor, I have a stent in my basilar artery for TIAs for the last 5 months. We didn't put that in. I put it in another hospital here in Philadelphia. Now, I mean, off-label in the basilar, off-label for TIAs, right? So, and she has absolutely no information. She doesn't know what kind of stent, not entirely clear why it was done. She doesn't know anything about it, okay? And she really doesn't even remember who her doctor was, okay? She's fully anticoagulated on warfarin. Well, so what? She's doing okay because she fractured her hip. And the orthopedic surgeons want her to take to the operating room to fix the hip. So they call us and they say, well, we want to reverse the warfarin with 4-factor PCC. Can we do that? And, you know, I said, no. I said, no, you can't. I don't know anything about this lady. I don't know if she's going to thrombose her basilar artery. I don't know what kind of stent she has. I don't know why she's on warfarin at all. You know, it just, none of it makes any sense. I guess she's on warfarin because she has posterior circulation TIAs. But you know what? They did it anyway. And I think they got away with it. But I had to go out of town, so I don't know what happened to her. But I think they got away with it. But, you know, they're just tough problems and you don't know how to deal with them. So we're done. Here's what I talked about. I tried to tell you all about the anticoagulant drugs, the antiplatelet drugs. I tried to talk about shutting them off for emergencies, shutting them off for elective surgery. I talked about who I think needs a bridging strategy, and our bridging strategy is usually, you know, particularly for warfarin to Lovenox. And we didn't talk about it, but, you know, the Lovenox, we say, oh yeah, it has to be off, you know, 12 hours before surgery. Well, you really have, we can stop it the night before. Well, it's really got to be off at least 12 hours before surgery. Lovenox hangs around, if you look at the studies, a little longer than you might suspect. So be careful about operating in the face of Lovenox, and be careful that it's gone long enough. How do we restart? I didn't tell you about that, bridging or a bolus dose. Suffice to say, you can bridge to a restart with Lovenox to warfarin if the patient is high risk. Bolus dose, we don't often use. Usually we just give the drug back and let it ramp up. And the question of devices with dual antiplatelet therapy, I don't have time to talk to you about today. It is an interesting question. So once again, I refer you back to this edited textbook. I had a lot of great chapter authors in this book, and most of what I said today is in this book, except the book does not talk about the reversal agents for anticoagulant for NOACs, because they weren't on the market when the book was published. So just another reason to do another one in a year or two. And so this is a great seminar, and it's actually, frankly, a brilliant idea in this very stressful time around the world, and it's fun to be able to interact with our colleagues, and I love it. And so, Professor Riveros, I thank you for the invitation to speak, and I thank your team for putting on a wonderful seminar, and I thank you for making it free for the surgeons around the world to be able to get you know, educational materials. And so I'm done. I'm going to put the little pictures back on, and if there are questions, I'll be happy to try to answer them for you. And I wish you all the best, and I hope that everyone stays healthy and well and safe in their home countries, wherever you may be. And Professor, I would hope that someday we get a list of all the people who was on this seminar, if it's possible. I would just love to know, not for my own, but just in general, I would love to know where people listen to this, and you know, who they were. It would be fascinating for me. So thank you very much. I appreciate the opportunity to be here. I'm done.
Professor Loftus, thank you. Thank you very much for such a wonderful lecture and your words. We have right now over 400 people that watch your presentation, and we have some questions that, if you don't mind, can answer. Okay.
Make them easy questions.
I'll try. How much time do you wait to restart anticoagulation in a patient who has been operated of subdural hematoma and has heart valvular disease?
Yeah, well, that's tough. I'm presuming you're talking mechanical heart valve. Usually, and subdural hematoma is probably the toughest problem. So, you know, for this, I would do several things, right? And I don't mean to not give you an answer. I'm going to give you an answer. But first, I would be in constant dialogue with the cardiologist. And my wife is a cardiologist, so it's easy because I could come in, I'm sitting in my bedroom right now, but I can turn to my wife in the chair and say, what should I do? Probably would talk to the hematologist, certainly would talk to the cardiologist, and I would not restart when a drain was in place. The drain needs to be out, okay? And I want a CAT scan before I restart. And I think the fresh blood needs to be gone. If there's a little residual subdural in a heart valve, I probably would start. It's a close call. So the answer would be 48 to 72 hours at the earliest, right? Because I leave drains in place. And so they're probably going to be in for at least a day or two. And then I do a CAT scan. And then if the primary disease is compelling, I would start. And with a heart valve, that means warfarin, you know.
Okay.
That's what it's going to be.
Okay. Next question. What do you think about the role of transamin in TBI, pre-op and post-operative?
Role of, I'm sorry, what dog did you say?
What do you think about the role of transamin in TBI, pre-operatively and post-operatively?
I mean, you must mean tranexamic acid?
No, they ask about transamin.
I'm sorry, I'm not familiar with that drug. Must be a different name for us.
Okay. What is your recommendation of the use of tranexamic acid in...
I'm sorry, go back. Start that one again.
The previous one?
No. I mean, I don't know the drug, but you know, this question, because I was talking and you were asking the question. I apologize.
Don't worry about that. What is your recommendation of the use of tranexamic acid in head trauma in your experience?
You know, we don't do it. I know people do it. We used to use tranexamic acid a long time ago. We used it for subarachnoid hemorrhage, in antifibrinolytic agent for subarachnoid hemorrhage, Amicar, we called it. We don't really do that now, so I don't have any personal experience with it. We don't do it for subarachnoid hemorrhage. I also don't do it for head trauma.
Okay. What is the actual utility of thromboelastogram previous to emergency surgery?
What a great question. God, the audience is so smart. I thought about talking about, and somebody's going to ask about the Verify Now also, I'm sure, right, for the platelets. But a TEG or a ROTEM, if you have a question, you can get the answer. And if you have a hospital that has cardiac facilities, you're going to be able to do a thromboelastogram, right? There's a chapter in the book about that. We don't routinely do it. Because we know the drugs, we reverse them. We don't routinely do a TEG or a ROTEM, and we don't do a Verify Now at all. And there's some, you might ask about Verify Now for platelet function. There is some debate about whether the Verify Now is accurate enough to be able to make predictions. I know they use it for endovascular devices to confirm therapeutic levels of thienoparidines before they place, for example, a stent. For trauma and for management of anticoagulation, we don't really do that. Or any platelets, we don't really do that.
Okay. Another question. I'm not anymore afraid to aspirin. Before, I just wait for 7 days. Now I wait just 3 days without complication. What's your opinion?
I'm making an assumption. The question is when to resume aspirin after a surgery or after a trauma?
The person used to wait 7 days before when the patient have aspirin. Now he just wait 3 days.
Okay, but
and he haven't any complication.
The question could be several, right? Is that waiting to do a surgery or to restart after the surgery?
To surgery.
Before to do the surgery?
Yes, sir.
You know, I'll tell you, all my spine surgeon friends, they're afraid of aspirin, okay? And they really want it gone. For carotid surgery, I gave the patient an aspirin the morning of surgery. It's not a problem for me. I didn't like Plavix, but aspirin is fine. Yeah, I guess it depends on what kind of surgery. I don't think I would do an intracranial procedure with aspirin unless it was really gone. I think for me, it depends what kind of operation you're talking about, but 3 days sounds pretty short to me.
Okay. When do you recommend start non-steroidal anti-inflammatory drugs and Toradol after cranial and spinal cases?
Yeah. I don't have a strong answer for that. 3-4 days, maybe. I don't have a strong answer for that.
Okay, next.
I'm sorry.
No worries. What about patients with leukemia with platelets less than 20,000 or less than 50,000 with an acute hemorrhage, brain edema? And what should we do?
It's a disaster. It's a disaster, okay? And they come on call. But old people come with myelodysplastic syndrome. The platelets are 15, 20,000. You transfuse the platelets and they're gone in a few hours, right? The first thing, you got to be involved with the hematologist for this, okay? And they'll tell you what to do. I'm sorry, I'm on call in the resident. I'm on call for the hospital. I just had to take a call from the resident and I'll ask him if I can call him back. One moment.
Don't worry, Professor.
Hey, Nick. Listen, I'm doing a video seminar with an international. I'll be done in 10 minutes. Can I call you back? Okay, thanks. Okay, bye-bye. I forgot I was on call. I'm not on call today. I'm on call tomorrow. Today is Thursday.
Today is Thursday, that's right.
Oh, I don't go on call till tomorrow. Why is he calling me? Okay, I'll call him back. Anyway, I'm sorry. Another question. Low platelets, myelodysplastic syndrome. There's no good answer. Okay, you give the platelets, they're gone. I mean, you hope and pray that the hemorrhage is small and it goes away without needing to do anything. Because I'll tell you right now, I'm not going to operate a patient with platelets of 20,000. I mean, I'm not going to do a craniotomy on that. I take a bad situation, I'm going to make it worse. So you got to get hematology involved, and it's a disaster.
Okay, next question. Sometimes we get patients with suspicious NPH, also on anticoagulants for heart problems. Yeah. So what do we do if we have to do serial lumbar punctures? I
wouldn't do it. I would, if they can't come off the anticoagulant, I tell you right now, I never did a lumbar puncture and cause a problem, but I saw it in a patient on Lovenox, once again in Chicago at Loyola. The neurologist did a lumbar puncture and she got a spinal hemorrhage and she wound up paraplegic. I mean, it was a disaster. And I operated the patient, but it was too late. We couldn't get her better. I would not do serial lumbar punctures if the patient's, even on antiplatelet drugs. Some people say you can do it on aspirin. I won't do it. I would look for another way to, to treat the patient. No, to make the diagnosis, there are other ways. I mean, you can take the patient off and put in a lumbar drain for a few days and see if they get better. There are other ways to make the diagnosis of NPH besides serial lumbar punctures. I would not recommend it.
Okay, thank you. There's the last question. When there is a complication of the endovascular procedure and they use tirofiban, what is their behavior?
I mean, the 2B3A, those things are short-lived drugs. I don't use them myself, so I don't know that I'm really qualified to answer that question for you.
Okay. Dr. Loftus, on behalf of CIEN and personally Dr. Riveros, I would like to thank you again. This has been a great lecture. We are really grateful and honored for your participation in the 2020 IWBNC. More than 3,000 people has registered to the Congress from over 100 different countries. And more than 400, as I told you before, has watched your conference.
That's great.
You are more than welcome to stay tuned to watch more lectures from other speakers. In a few minutes, we will have Dr. Christopher Ogilvie doing his lecture, Contemporary Management of Rupture Aneurysm in the United States. To get the link for this upcoming conference, please follow the link pinned on the chat screen and check the agenda on our website, signhost.com. Dr. Loftus, thank you again.
Thanks very much. I tell Dr. Ogilvie, I'm sorry, I have to get on an FDA conference call at 5 o'clock, so I can't listen. But to all of you in the audience around the world, thanks so much for your interest. And I hope you got some information that was useful to you in this lecture. Have a good day. Have a good night.
Have a good day, sir.
Okay, bye-bye.